I'm not seeing myself dying with antiretrovirus. I don't want to lie. Before I was initiated on antiretrovirus, I was having fears that one day I'll die. This is what will happen to my children. But I'm living my life.
The cost of HIV drugs has dropped enormously. Not long ago, treatment was something which was only available to the wealthy. But now, more than 4 million people around the world are being treated with antiretrovirals, or ARVs, an effective form of treatment that allows HIV patients to live a long and healthy life.
In terms of impact, we've seen people's lives being improved, people's quality of life being maintained, and less of people dying of HIV-related complications, less of hospital admissions within facilities, less of patients coming to seek help for treatment for opportunistic infections. So with the advent of ARVs, it has improved, especially for us on the side of the healthcare worker and healthcare systems. It has lessened the burden of workload of what we are doing.
However, the HIV crisis is still far from over. In 2009, 2 million people died of HIV-related diseases. Close to 60% of those in need of treatment are still not getting it.
A lot has been done, but a lot more needs to be done. And I don't think we can always say it's enough. We still are facing new challenges that are coming up. Already now we have quite a lot of people who've been prolonged life on this antiretroviral therapy that we need to sustain this therapy for them for the rest of their lives.
MSF has started to observe a very worrying recent trend, where some international donors are presently capping or even reducing their involvement in HIV/AIDS.
As we speak, people are dying of AIDS. Millions are dying. There is still 6 million in Africa waiting to start treatment. It means they will deteriorate, they will get ill, and they will die. And what's worrying, in spite of the fact that there is so much more to be done, donors seem to lose interest in the fight against AIDS.
The President's Emergency Plan for AIDS Relief in the U.S., known as PEPFAR, is a major global donor for HIV/AIDS. In 2009, PEPFAR reduced for the first time its budget for purchasing antiretroviral drugs. This has already translated into a reduction in the number of new people who can start treatment. Dr. Margie Hardman runs a PEPFAR-funded clinic for HIV patients in the Mpumalanga province in South Africa. In November 2009, she was told to stop enrolling new patients.
We were told at that stage that we couldn't put more patients on ARVs because of the funding was insufficient for that. So we were capped, I think it was at 2,300 or 2,200 patients, and we were told that we just could not put any more patients on. We actually had to severely restrict it, so basically we had to turn those patients away. Those that couldn't start is worrying, because quite often they were really very sick, and we don't know how many of them died or what happened to them, unfortunately. It's very hard, patients come here, they've heard it's a good clinic, they've heard they can get help here, and to be told, no, we can't help you now, you have to go somewhere else.
Dr. Hugo Tempelman is chief executive of the Ndlovu Care Group, which is another South African organization active in HIV/AIDS.
What we see now happening after 6 years of proper management is that there comes a donor fatigue from all sides, and they see that the successes of the treatment is going to be a liability. What I mean with that is, once you put an HIV/AIDS patient on treatment, you have made a commitment for life, and that's difficult to sustain for donors. What do we see happening now with the recession? We see that donors are withdrawing in such a fast way without making them sustainable within the Department of Health.
In 2010, the Global Fund, the biggest donor in the fight against HIV/AIDS, faces a major funding shortfall. The US, the Netherlands, Ireland, and Germany have already announced that they will be providing lower contributions to the Global Fund. Other donors, such as UNITAID and the World Bank, have also announced reductions over the coming years in the funding for HIV. Less funding from international donors means more and more patients will go untreated, because many low-income countries continue to depend on foreign funding. The current economic crisis makes it even harder for governments in low-income countries to respond adequately.
About 95% of the HIV programs in Kenya are funded by external donors. If the international donors and partners decide to withdraw their funding, then the program may not be sustainable according to the present funding levels by the government.
The lack of substantial commitment from donors is straining already fragile health systems. In several countries in sub-Saharan Africa, drug stockouts and other problems with drug supplies are already a reality on the ground.
MSF teams are increasingly confronted with requests for help. The Ministry of Health, local or international NGOs are asking us to step in with emergency supplies to avoid stockouts. In Malawi, the Ministry of Health was facing a threat of stockout. MSF had to bring in emergency supplies for some 3 months or so. In DRC, there is often problems with very low stocks of ARVs, so MSF provides support to other NGOs to make sure they don't run out.
Because of the scarcity of available funds, discussions are also taking place in the capitals of Kenya, Democratic Republic of Congo, and Uganda to make patients pay for their treatment. But many people who are HIV positive belong to some of the poorest groups of people in the world. MSF's experience has shown that making people pay for treatment acts as a serious barrier to accessing care, because many simply cannot afford to pay.
Antiretrovirals should be accessible to everybody, because by the time antiretrovirals were available, it was only available whereby people were affording to buy with their own monies. And if you look at that, people who are managing are the only people who should be able to live. And that it is very wrong according to the constitution of our country, because in section 9, we say we have a right to equality. We need not to be discriminated in any way. So if it would be said that people should buy antiretrovirals for themselves, it therefore means the poor would die because we'll never be able to buy antiretrovirals for themselves.
If not enough money is put into the funding pot, more people will die because they could not access treatment. Public health structures in low-income countries could once again become overwhelmed with dying patients.
If they decrease the funding for the HIV, then it will mean more people die and we have more orphans, and some will lose hope and go to the home areas where they'll die, and it will be the end.